Our final speaker today is Professor Hayley MacGregor. She's a Professor of Medical Anthropology and Global Health at the Institute of Development Studies at the University of Sussex. And she's going to speak today on COVID-19 and pandemic preparedness, local and global concepts and practices in tackling disease threats in Africa.
Hi, good afternoon. So I continue with the topic of pandemic preparedness, but as you heard, I'm actually going to take us beyond the UK and Europe to contexts where I work. I originally trained as a doctor in South Africa before I became a medical anthropologist. And I'm going to talk about findings from a Wellcome Trust-funded social science project. This was purely anthropologists, a collaborative award that's just coming to completion. We've had it for the last 5 years, and this focused on the concept of pandemic preparedness, which is the kind of research we do in social science, and this focused particularly on tackling disease threats in African settings. Okay, I don't think maybe this one. Aha, it was upside down. The project was led from the Institute of Development Studies at the University of Sussex, where I work, led by our director, Professor Melissa Leach. And it involved this collaboration of medical anthropologists, both in the UK and France, but also in Sierra Leone, Uganda, and Senegal. And my full list of co-authors for our work is in the abstract that I submitted for this meeting. So the central focus, not advancing, of the project is on diverse understandings of this concept of pandemic preparedness. And we were particularly interested in different understandings at local, regional, and global levels of what pandemic preparedness should mean, but also documenting what people would think would be the kinds of practices considered appropriate for achieving outbreak preparedness. So what do different people think should be done to prepare? And I'm no doubt you're all aware that in the years preceding the pandemic, of course, this concept of epidemic preparedness had actually gained quite a lot of prominence in sort of global health discourse, particularly because of the West African Ebola outbreak. And there'd been several commissions and so forth looking at how to strengthen pandemic preparedness, including in African settings. But of course, as we've been hearing from these lovely presentations from my co-panelists, the COVID pandemic, of course, has thrust this political spotlight on this idea of preparedness. And right from the outset, it called into question some received assumptions, because as we all know, it became evident that countries that had scored quite highly, in fact, most highly, on evaluations of preparedness done by these various pre-pandemic commissions, actually quite rapidly were shown to be faring worst in terms of outcomes. And this really has prompted a rethinking of what preparedness is, what it should constitute, and also the wider governance of pandemics, as we know indeed from the current pandemic treaty process that is underway. And as Tabitha was explaining, the pandemic also very much foregrounded the contextual natures of the practices and experiences of disease outbreaks, and how the kind of methods to control pandemics really played out very differently in different social and political contexts and places with different disease histories. But when we were first funded by Wellcome, in fact, in 2019, preparedness wasn't so widely discussed, but several of the colleagues in the team had been involved in studies in West Africa during the Ebola outbreak, the Ebola response anthropology platform in particular, which gave very high-level advice, including to the UK government. And there had become a particular research interest in the role played by local people in mobilizing to respond to Ebola, and people organizing to protect themselves. You might have noticed the photograph in my opening slide was actually taken in a village in Sierra Leone during that Ebola outbreak of someone wearing homemade PPE. So that research had raised questions about what kind of preparedness might actually be happening or be present at those kinds of local levels. And we termed that preparedness from below. And our Welcome research was really focusing on asking what kinds of connections or disconnections might there be between these understandings of preparedness that we were very familiar with at WHO or in international organizations, and then these local responses and possible local concepts of preparedness to outbreaks, how to respond to disease, but also to a wider set of misfortunes that people face at quite a kind of continuous level in those kinds of contexts, such as Sierra Leone. So we were asking research questions like, might local knowledge and understandings, in fact, be useful for global responses to consider? We were asking who was being prepared for what, and how and by whom, these kinds of questions about politics and power and who's calling the shots. What might be learned from people living with these multiple health-related and other uncertainties in African settings. This concept of uncertainty and living with uncertainty on an everyday basis was quite central for us to our research. So this work involved ethnographic research, which is basically a method very prevalent in anthropology based on observation, informal discussion, but also more formal interviews. And this ethnographic research was conducted in rural villages. We chose them because they'd encountered Ebola, both in Sierra Leone and Uganda, respectively. And we focused in these village settings on people's responses to uncertainties in these forms of ongoing threats to health and life. Remember, this was pre-pandemic. And we were exploring our hypothesis that some kind of preparedness from below might be operating in these settings. And we were interested in local capacities that would be mobilized in response to everyday uncertainties, but also these exceptional events, including floods, food insecurity, but also disease threats. What kinds of networks might people draw upon? What kind of agency was evident in villages, and what forms of public authority and knowledge became important? In other words, who did people trust to act, and what kinds of understandings and knowledge were they drawing upon? Of course, in the second year of our project in 2020, the pandemic arrived, and so we really swiveled our focus to look at these evolving understandings of COVID-19 in rural African settings, where the disease actually took a very long time to arrive, but also tracking how public health measures and messages were received and experienced, and these social relations and responses that were being mobilized at that stage, largely also to respond to the kinds of effects on livelihoods that quite stringent pandemic measures, particularly in Uganda, had engendered. So I just want to talk, particularly also after Callum's very interesting talk, just to explain a little bit about how, as social scientists, we saw this work on preparedness from below as being able to sort of engage with wider policy debates. And in social science, we obviously, because our work is qualitative, we think of impact in slightly different terms. So on the one hand, we have the kind of impact where we really look at sort of social contexts, different understandings, and bring these to the fore, the kind of work that Tabitha was talking about. But also we try and look at what are the big ideas circulating in international organizations, and can we kind of also engage with those ideas and actually have impact also at a conceptual level to sort of critically think about how things are framed. For example, things like vaccine hesitancy, as Tabitha explained, or indeed this idea of infodemia. So in terms of preparedness from below, Melissa Leach and I, for example, became members of the WHO Roadmap COVID-19 social science expert group. I'm sure people in this room were involved in those expert groups. There was also a social and behavioral science expert group. And here we were contributing to discussions, particularly because this idea of community-centered and community-led responses actually was becoming quite prominent in WHO at that time. So, for example, we were looking, I was involved at looking at home care for COVID-19 in context with limited resources, and what kinds of community-led responses could be harnessed in that setting. And indeed, I think it was in about 2021, a new unit actually was established in the WHO Health Emergencies program, actually called the Unit for Community Readiness and Resilience. So there was this sort of, the seed that had been planted in Ebola in a way was growing, and there was this interest also to thinking about what kinds of capacities might be present at local level that could be harnessed. And there was particularly this idea of resilience. So I was involved actually, probably more as a critical voice in a review that unit did on this idea of local resilience and how to sort of assess or measure capacities for resilience, and in a way that how we would engage in that context, the sort of set of caveats, I guess, if one's thinking about a context like Sierra Leone, where you have a very weak health system, people have very limited resources, is that in a way there's a danger in sort of relying too much on this idea of local responses and resilience. And in fact, we were trying to shift the debate to say, how can one actually support and strengthen systems to enable greater local capacity and to support community-led responses and at that level. We also had one of our project researchers who was on UK SAGE as one of the medical anthropologists, actually also contributing to this idea of the need to strengthen health systems in the longer term, particularly looking at the fact of longer term austerity and health inequities in shaping trust in health interventions. As Tabitha was talking about, that's in fact how our Ealing work initially was seeded. So I just want to give you a snapshot now of our fieldwork findings so you can see how we, in a way, what we were drawing on to try and make these policy interventions. So the ethnographic fieldwork, first of all, just briefly, some of the insights from our fieldwork. So in these contexts, in fact, in these two countries, in fact, the mortality from COVID-19 probably was never very high. The data are very difficult to assess. But in the villages, certainly, people were not seeing people dying from COVID-19. But the effects of the public health measures, particularly in Uganda, where they were enforced in very stringent ways, meant that people couldn't continue their livelihoods. For example, going to their fields in Sierra Leone, there were market closures that had a huge impact on farmers. At the same time, while there were all these COVID public health measures, there were floods in Sierra Leone that severely damaged crops. We also had other disease outbreaks. In fact, in our field site in Uganda, there was an Ebola outbreak close by quite recently last year. So people were really dealing with these multiple issues, intersecting acute and chronic challenges in the context of these very precarious livelihoods and multiple uncertainties. And what we did there was to really link to quite a lot of social science theoretical thinking around this idea of precarity. And we came up with this idea that people were negotiating, intersecting precarities. So trying to draw on sort of different ways of mobilizing different networks to try and respond to the public health measures, but also to resist them. There was quite a bit of that, particularly resistance to the military in Uganda, but also negotiating with authorities, bribing to try and get around public health measures to be able to farm and to sell their crops. And really the point here is that preparedness measures really have to take account of these very complex challenges that people face, these multiple competing challenges, not only disease outbreaks, and that there's a real sort of difficulty in those kinds of settings in terms of what to prioritize in terms of risks and the sort of general context of people's lives being so complex. In this sense, we also saw how people really drew on a lot of local action, just had been seen in Ebola, but also very much informal forms of public authority. For example, in Uganda, various vigilante groups that were helping people get access to testing. So the importance also of recognizing that the trusted forms of authority locally are not just your formal state health authorities. In Uganda, also militia groups on the border have a lot more trust locally than the Ugandan military who were enforcing the measures. And these kinds of politics around public authority really become important when one's trying to roll out a set of measures, be those for COVID-19 or for Uganda. And of course, the knowledge about that context really matters also for implementing pandemic measures, particularly also knowledge of these national and regional political environments. And that, of course, also has implications for these ideas of health security. So in Uganda, for example, where one has a very authoritarian regime under Museveni, it's been well documented that the kind of license around health security and pandemic measures that was given, I guess, by global directives around COVID-19 were very conveniently harnessed to enforce what was called a scientific election, where the opposition were effectively excluded from electioneering on the grounds of the public health risk, allowing Museveni to achieve another landslide. And at the same time, in the rural area where we were working on the border, a very heavy military presence that people experienced as extremely violent, and that in fact, rather than increasing their health or security otherwise, actually multiplied insecurities. So we have to be really careful how these kinds of discourses get mobilized also by politicians. So Tabitha talked quite a bit also about vaccines. I'm not going to go in detail. We did a lot of work on COVID-19 vaccines, and just to emphasize that point, that the vaccine hesitancy that was seen, particularly in Uganda, did tend to get put down to the kind of spread of infodemia and social media messages into African settings. But we actually worked rather with the concept of vaccine anxieties, because there were people both wanting vaccinations and unable to get them, and people that had quite significant concerns about vaccination in Uganda also because of the distrust of the state, corruption, geopolitical intentions around Chinese vaccines. So these technologies land in particular social, historical contexts, and one has to consider that really when one's understanding these anxieties. Finally, I just want to talk about the last piece of work we've done, which might in a way be more immediately interesting to this audience. And that was in this final year of the pandemic, we actually, with our researchers also in Senegal, who'd been looking at some of the regional West African institutions for preparedness, we conducted 25 interviews with a whole range of global health actors at international and regional levels, including in WHO, Gates, CEPI, a whole range of foundations, organizations, including some academics or people who moved between academia and practitioner roles. And we were asking interviewees how their understandings of preparedness might have shifted as a result of what they'd observed or experienced during the COVID-19 pandemic, and what they saw as the priorities and challenges for future preparedness. And actually in two of the talks we've just heard, there's been some very beautiful illustrations of the kinds of initiatives and priorities that came to the fore. So what we found, not unsurprisingly, that different people had sort of different areas that they wished to focus on, but most of the respondents were particularly interested in this idea of readiness to respond. So I was quite interested in your quote, Lemke, because this idea of readiness really seems to have come to the fore as a result of the pandemic. And there we had our interviewees discussing these new architectures, new platforms for experts, this interest in real-time data informing policy, as Callum was talking about, and a lot of really interesting initiatives in that space, including obviously with CEPI, vaccine platforms, pharmaceutical platforms to the 100-day mission, all of those kinds of readiness interventions. However, several interviewees obviously quite interestingly really wanted to emphasize that unless prevention, health was the sort of driving force of preparedness, we wouldn't be getting anywhere for future pandemics. And finally, again, interestingly, what Lemke presented, another idea that really came through strongly was this idea of preparedness to protect the health of populations, and a lot of discussion of longer-term health inequities that really shaped outcomes in the pandemic, and this idea of a whole society of approach and a sort of longer-term temporality of preparedness being so critical, rather than just focusing on the kind of quick fix measures of rapid response capacities. And while some people really tended to just foreground one set of practices as important, there were actually also several people, including quite senior WHO people, who really emphasized that COVID in particular had shown them that several approaches were necessary and required in parallel. And of interest, of course, to our project, where we were looking at preparedness from below, we definitely detected a sense in these reflections that people had really learned the importance of, in particular, of connecting with local level initiatives and working with communities. And there, which was quite gratifying, there was a bit of a shift from this idea of just top-down health education. You know, quite often social science is seen as just about informing risk communication and community engagement, but much more of a sense of the need for dialogue, more flexible approaches, fostering relations of trust. The word trust was spoken about a lot. So it did feel as if things had shifted there. And of course, we would say that these standard technical approaches to preparedness have an important place, but preparedness and response also involve social and political processes. And I just want to talk in my last minute about this wider theme of politics and power that really came through, which was interesting. You also picked that up, because several respondents spoke about being quite surprised to observe the influence of politics in how the pandemic's played out. For example, the effects of party politics in terms of what measures could be implemented and so forth. I think what we heard was that fewer of this particular group of interviewees, fewer people really reflected on the importance of being able to navigate politics in order to ensure a more effective response. And very few actually discussed the inherently political nature of the science policy interface, of policy making and also policy implementation. So it did seem that there wasn't that much awareness that that was actually a set of political skills that researchers, policymakers, practitioners needed to acquire. So finally, just to say that the regional actors, on the other hand, did reflect on politics quite a bit. And this is sort of my final point, to sort of give us a more global view of pandemic preparedness. They were quite direct in reflecting on the regional global dynamics that came to the fore in the pandemic. In particular, the power relations they felt that meant that they were unable to shape responses, particularly in African settings, to local priorities and epidemiologies. And this was particularly spoken about in relation to how COVID-19, how Africa at the outset was sort of default, kind of framed as an area of great vulnerability. So there was kind of negative framings of Africa, but also in relation to COVID-19 vaccine strategies in African settings, particularly in Senegal. There'd been a big national debate about whether universal COVID vaccine was indeed a priority there, and given the sort of epidemiology in that country. So very interesting questions also about, from their side, about inequitable access to vaccines on the one hand, but also this debate about different priorities in context with limited resources, but also multiple coexisting outbreaks. So there was a lot of talk from our regional and interviewees about this idea of competing priorities and how they have to juggle with that. So at the same time, also calling for greater self-reliance and production capacity in African settings, which of course is also a priority of CEPI. So at my final slide, we then picked up on this point about politics and power and ran a public webinar on pandemic preparedness, shifting power, in the closing months of our project. And really we distilled these three questions for the sort of policymakers on that call, and really focus on the central issue of how to shift power in pandemic preparedness and response. Firstly, through more attention to these local, decentralized preparedness from below initiatives, but also to think about these global regional relations and what more localized power and agency might also look like in future in terms of global institutions and how to really build a pandemic preparedness for the whole world. Thank you.
Thank you very much. That was a really insightful and important presentation. I think a great high note to end our presentations for today.